Do it.
You good?
What's
You
up,
ready?
everyone? Welcome back to another episode of Buzzwords Med. Today we are covering dermatology. As always, I am here with Bobby. Bobby, how are you doing today?
Skin is in.
Skin is in. Bobby and I have been going back and forth. This is like our fourth or fifth intro. We've been diddly daddling and
We've definitely been diddling.
So it's going to be a fun episode. Yeah, Bobby, what are you drinking today?
I am drinking Little Huma by Shorts Brew. What are you sipping on?
Huma.
Huma?
I'm drinking the Rolo, the salted caramel stout by Longship Brewing. It's another one of the brews that they passed out to us and makes
Nice. Yeah, Shorts sent me this one as well.
Recommended it.
Cool.
Can you see the bottle or the can again for the Shorts? That look cool.
Mm-hmm. It's a nice yellow with a green. Trying to avoid the glare, just making it worse.
What kind of a brew is it?
It is a low-cal, low-carb IPA. Because I'm watching my figure.
That makes sense. I'm glad it finally got to you.
Yeah.
Fantastic. So today's episode's a little bit different. It's going to be very high yield and, of course, very engaging for everyone. But I've created this PowerPoint of incredibly tough, high yield dermatology concepts for Bobby, who's notoriously bad at derm right after pediatrics. So, with that being fair, with that being said, I'll give Bobby a prompt. He'll answer it to the best of his abilities. He's brought 2 beers today in anticipation of the questions. If he gets it right, I'll drink. If he gets it incorrect, of course, he'll drink. Does everyone understand the rules, Bobby? Bobby, are you aware of how we play this game?
I don't really understand, so I am actually just going to drink whether I get it right or wrong. So it's really up to you to kind of police yourself in terms of whether or not you're going to drink. But besides that, I'm ready to rip. Let's go.
All right, let's do it. I'm scared.
Why are you scared? You're the one.
Oh
no.
I should bring a paper towel each time because I spill every time.
The trick is to tap the top, and then it doesn't.
Oh, that's interesting.
Is it like the Clamato?
Did our Clamato episode ever get in? I think it did.
I think it
I don't remember. I think it's on our website. All right, guys. So, Bobby, my first question to you. You have a gentleman come in, and he says, "Hey, doc, I have a new belt. I was wearing it. Everything was going fine. And then a couple weeks later, I started getting this really angry red rash right where the belt buckle is.
Mm-hmm.
What kind of hypersensitivity reaction is occurring?"
That sounds like a type 4 to me.
Well done.
It's
Why?
nickel, boy.
Fantastic. If we want to go to the next slide, we can show our viewers. Yep, exactly. So this is an example of a nickel allergy. You can see it in the ring shape on the above image and the belt buckle in the below image. It's a type 4 contact dermatitis. It's classically belt buckles, rings, things like that. The treatment is just symptomatic, steroids, topical, and then, of course, abstaining from using these in the future. You could do things like patch testing and things like that, but for the purposes of the step exam, just understand what it is, what hypersensitivity reaction it is, and kind of common reasons someone could have it, nickel being one of the most common.
Yeah, I think nickel's actually maybe latex might be more common, but I think nickel's actually besides latex, the most common allergy that people have to for skin contact. And I guess it's because nickel's in the majority of inexpensive jewelry. It's a very common alloy, so let's keep an eye out for it.
Nickel's actually one of the more common components of a lithium battery. I don't know if you knew that.
Mm-hmm. Yeah, isn't it like nickel metal hydride?
It's actually better than iron.
Interesting.
Yeah, but it's a little bit more rare than iron, so
right.
That's why you need a balance of the two. I don't know if you can tell, I just listened to the Elon Musk podcast from Joe Rogan. So anyways, I'll drink to that. Well done.
Cheers. As a follow-up question, could you remind the viewers at home kind of the underlying pathophysiology of a type 4 hypersensitivity reaction?
Indubitably. So this is a specific T cell mediated reaction. So the antigen will be exposed. Dendritic cells will take that antigen, will then go prime the T cells, and then the next time you get exposed to whatever antigen that was, the T cells will have this delayed hypersensitivity reaction. So unlike the other three, which largely have a B cell component, type 4 is T cell.
Yeah, exactly. And that's also part of the reason why it's delayed as opposed to like a type 1 where like mast cells and stuff can function essentially immediately versus the T cells need to be sensitized first before you can have the actual like skin reaction occurring.
Right.
Cool. What else
Fantastic. So I'm starting you off easy, Bobby, and I hope you're getting your confidence nice and boosted because I'm going to just rip it apart with these next few slides. So you have a gentleman come in. He's 45 years old. He has a lot of flaking around his mustache, down the T-zone of his face, and he's concerned. He's had this before, and he got a topical ointment, and it helped, but it's now back. And you're talking to him, you're educating him about him, and he goes, what patient populations typically suffer from this? And you say, oh, there's actually two pathophysiologies that, for some reason, can have a very severe form of this pathology or this growth. What two pathophysiologies or pathologies will have an abundance or an outbreak of this growth?
You are describing seborrheic dermatitis, classically associated with 1, HIV, and 2, Parkinson's.
Fantastic. Are you reading my notes, by the way?
I am not.
All right, I can't prove that, but I believe you. And that was very well done. I didn't think you'd get that. Have we talked about that before?
We've talked about both of those skin findings before.
Have we done a derm podcast before?
No, it's just something that we always bring up as a fun fact.
Have we done this?
Have I been here? Where do you think we are right now?
Oh, that's good. That reminds me of the Scrubs episode.
Yeah.
Whoa,
I know.
I didn't know you were a Scrubs.
I'm wearing Scrubs. How would I not know about the show?
I didn't think you were a Scrubs fan. That's interesting.
I'm not. I've just seen that episode with you like 6 times.
That's such a good episode. Oh, man. Check it out, guys. Season 2. All right. So, that's right. Seborrheic dermatitis is an overgrowth of essentially a fungus. You can treat it with multiple things: topical steroids, selenium sulfide, zinc shampoos, yada yada yada. Two populations, HIV and Parkinson's, you got to think about. Well done. So, the next patient comes in and they have this scaly rash along their shoulders, and they pick at it and it bleeds, and they scratch themselves, and sometimes new scaly flakes come up in where they scratched. And you look at their nails and you're like, oh, that's interesting. What's a finding that you can find in these patients in their nails?
They have abnormal terminal capillaries in their nail beds. Or they can have nail pitting.
Yeah, you're right. You're right regardless. Yeah, psoriasis. So this is psoriasis, right?
Yes, it is.
Fantastic. So psoriasis, you get these erythematous plaques. You got the silvery scale. They're probably not going to ask you about treatment other than if it's mild. You can probably just put topical steroids on some certain parts of it. But treatment for psoriasis is so varied nowadays. There probably is no best answer on this test. So I don't think it's fair that they would test you on that. So regardless, people with psoriasis, they can have nail findings. Pitting is super common. Onycholysis, kind of like oil spots. Nail crumbling, it looks like someone's been like working as a plumber, or seems like someone's just nails are just unkept. And then if you have a dermatoscope, you can actually look at it and you actually see like little actual splinter hemorrhages in the nail as well. So those are all a couple findings. I'm sure there's more, but those are the ones that I wanted to relay to our listeners and our viewers. And you can see an example of onycholysis nail findings on the images on this slide. Well done, Bobby. I think I have to drink because...
I think you do. And I will too. I have a follow-up question for you. So when you pick at psoriasis and it bleeds, that has a name. What is the name of that sign?
Yep, it's named after the German physician Dr. Auspitz, so it's the Auspitz sign.
Nice. Very good.
I'll have a follow-up for you since you're hitting me with those 1-2s. When you scratch or you injure yourself and your skin in that scratch, a new pathology or the pathology that you have arises in that scratch. So let's say you scratch yourself and psoriasis forms there, or you scratch yourself and if you already have vitiligo, it causes some vitiligo changes. Do you know the name of that phenomenon?
That is the itchy boo-boo phenomenon.
It is very close. It's actually the Koebner's, Koebner.
Oh,
Not super
I
high
have
yield,
actually heard that before.
but something for the awards, because at least if you do derm rotations, they love the Koebner's phenomenon. Well done.
Cool.
All right. So the next patient I have, Bobby, comes in, 19-year-old female, and she has these interesting annular lesions across her palms, her arms, and parts of her torso. You would say they're even targetoid. And she says, I know there's a lot of reasons that I can have this rash, doctor, because I've done my research. But what are some of the most common, or what is the most common etiology of these lesions? In which you would respond.
Are you referring to like small targetoid lesions, like with a necrotic center, or are you referring to maybe larger, more bullseye type targetoid lesions?
No, multiple small targetoid lesions across her whole body, not just one big one.
Mm-hmm. I would say the most common reason is idiopathic.
All right, give me a reason that's not idiopathic. Or tell me what it is first.
So you're referring to erythema marginatum.
Close.
Erythema.
The M is right. And remember, there's multiple across her whole body.
Yeah. Erythema chronica migrans is Lyme disease.
There's multiple, and they're like different shapes that are like they're formed a little different across her whole body.
Is it just erythema migrans?
Erythema multiforme, right?
Oh, right. Damn.
And for the listener who's been following us throughout our whole time here in our podcast, I've asked Bobby on 3 separate podcasts about this rash, and he could never remember the name of it. It just got you rash.
Yeah.
Forever.
That's a good follow-up question. Like if you're ever just trying to stump me, you can just ask me and I won't know it.
Yeah. So I think erythema marginatum is the one that you can find in, I think that's the Ian Jones for rheumatic fever.
That sounds right.
So erythema multiforme, top number one reason, HSV, so herpes simplex. Mycoplasma is the bacterial infection you have to think about, and then a lot of drug reactions. And here you can see it on the images below. Perfect. And yeah, you can have that dusky center. And if you got a bunch of it and it started getting painful and started sloughing off and having a positive Nikolsky sign, you might be worrying that it's transitioning into something much more dangerous. And what would that be?
So that would be Steven Johnson syndrome. Or
perfect. And then what's the barrier to make it TEN?
It is, I believe, 30% body surface area.
Yep, perfect. So that's right. So if you go to the next slide, you can see someone who's transitioned from EM all the way to SJS TEN. In this case, the treatment is ICU level of care. Essentially, you treat them like a burn victim because they're going to have a lot of exposed skin, a lot of electrolyte abnormalities, fluid loss, etc., etc.
Yeah, isn't the mortality for like this, once it gets to this point, fairly high? Like in the 60 to 70% range?
Definitely. It's really one of the few dermatologic emergencies. It's one of the reasons a dermatologist will wake up in the middle of the night and maybe go into the ICU or maybe at least talk to someone rather than just look at some pictures on their phone and make an assessment.
Well, I'll drink
very
to
dangerous
that.
stuff. I'll drink to that. All right, Bobby, you're doing better than I thought you would. I knew you wouldn't get that one. Well, I thought you wouldn't. But the other ones, I'm impressed so far. So let's keep moving. So
good.
The next patient I have comes in. She is a 52-year-old female. She's seeing a pulmonologist, and there were some suspicious findings when she went in for a chest x-ray, and they found that she had a lot of she had some opacities kind of in the hilar region of her lung. She has a little bit more short of breath. And you do a full body exam, and you notice that she has these really painful bumps, red painful bumps on her legs. What are they?
So
Let me know if you want a hint.
I know what they are, I just don't remember what they're called. She has like either Sjogren's or like systemic sclerosis. Those painful bumps on her leg are don't remember what they're called.
Let me help you out. So this woman came into a pulmonologist. They're concerned about a disease. It's actually a granulomatous disease, and she has some hilar lymphadenopathy. She has an elevated calcium, and they do a full body exam, and she has these kind of red nodules that are painful across her legs and her arms. Does that help at all?
No.
Fantastic. So these painful erythematous nodules are like Erythema nodosum.
Right.
And they're incredibly tender to touch. They're seen in a lot of patients. Very specific pathologies that we should know about when we see erythema nodosum. Those include sarcoidosis, which is what I was getting at here. Inflammatory bowel disease, so Crohn's or ulcerative colitis. One of the classic things is erythema nodosum. Multiple infections. If you think about coccidioides, for example, and you think about the sketchy and the red lesions there, erythema nodosum is something that you can see there. And then some drugs can do it as well, sulfa, birth control, among other things. But sarcoid, IBD, coccidioides, I think those are the big things. Treatment is just removing the triggering factors.
Okay. I think I have what's the term when you like learn something and then you learn something else and it like kind of overwrites what you learned the first time? I think it's like interference. I think I'm very susceptible to that with the different erythema terms.
Yep. Interference. There's so many. Erythema marginatum, erythema nodosum, erythema multiforme.
Chronic migraines. It just goes on and on.
Erythema, you love it. Everyone say it with us. Erythema, erythematis, maculopapular. It's beautiful. It's the go-to words. All right. Oh, there you go. That's what our viewers and listeners like. All right, Bobby. So we talked about SJS and TEN as an emergency in dermatology. We actually have some other really severe diseases, one of them being actually potentially life-threatening, so one that we should consider. And those are our blistering diseases. And the two blistering diseases we often talk about are pemphigus vulgaris and bullous pemphigoid. So I think what's important for our step 2 listeners and viewers is to understand how to differentiate one from the other and just the subtle hints that they can see in the passage that will help them move towards one diagnosis or the other. Because sometimes the stem won't give you all the information that you need because it's classic. I mean, you can say, desmosomes versus hemidesmosomes, like the stuff that we all remember from step 1, but sometimes there's some subtle differences that can help point you to the right direction. So, pemphigus vulgaris and bullous pemphigoid, just off the bat, which one is more dangerous?
Pemphigus vulgaris is more dangerous because it is more vulgar. Oh, am I not supposed to look at that slide yet? Sorry.
Yeah, just keep that off for now. But yes, fantastic. Pemphigus vulgaris is more dangerous. Fantastic. Which one will have the Nikolsky sign be positive?
Pemphigus vulgaris.
Right, so you'll rub the skin and actually slough off. Which one will you see intact blisters for?
Bullous pemphigoid.
Right, because remember, the antibodies are against the hemidesmosomes, which are attaching the epidermal layer to the basement membrane, and because of that, you have this nice thick epidermal layer still intact, so the bullae should still be intact, versus pemphigus vulgaris, where the antibodies are kind of just attacking all the desmosomes, and it's kind of just more, all over the place, and you never really have the strong epidermal layer again, so you can actually have a lot of basically pop blisters and flaccid ruptured blister quality versus tense and firm. All right, and so we already just talked about pemphigus vulgaris as desmosomes, and then bullous pemphigoid is hemidesmosome, and then the hardest question is, do older patients, are they more likely to get bullous pemphigoid or pemphigus vulgaris?
I believe older patients are more likely to get bullous pemphigoid.
Yep, well done. So the more dangerous one is actually in younger patients, and by younger I still mean like 50 to 60. Older is like 70, 80s for bullous pemphigoid. And then finally, this question, even a lot of derm applicants don't know this, but which one tends to evolve the mucous membranes?
Pemphigus vulgaris can involve the mucous membranes.
Well done. Very nice. Yep, that's exactly right. Did you get any of those wrong?
I don't think so. And I have one more follow-up for you. Yeah, that's like 7 drinks you got to take, by the way. What do they look like on immunohistochemical staining?
Fishnet, and so pemphigus vulgaris would be a fishnet, and then bullous pemphigoid would be probably just a linear deposition.
Yep, exactly. And if you can remember those, it also helps you kind of remember which one's more serious, because like the fishnet's all over versus just the basement membrane. And then if you think about like bubble wrap, if you're trying to pop bubbles, like just having one layer is less likely to pop versus a fishnet. Like if you cut an X through it, then it'll rupture, which is pemphigus vulgaris.
Love the bubbles. Love the bubble analogy. Anytime someone says bubbles to me, it reminds me of that what was it, a shrimp in Finding Nemo that just loved the bubbles in the fish tank. Anyways, I digress. Bobby probably doesn't understand. He didn't really have a childhood.
Who's Nemo?
Why are we trying to find him? Well done. Okay. Yeah, I took a nice long poll for our listeners at home.
Good.
All right, Bobby. So I have a 42-year-old gentleman come in really tired, just feels fatigued all the time. Actually has these really erythematous, like almost vesicular, red, angry, itchy vesicles all over his gluteal region, his lower back. Sometimes they pop up on his elbows. You're concerned about an underlying disease, and so you tell him the best treatment, and really the only treatment that's going to cause these lesions and his symptoms to go away, is what? I know it's very vague. Let's see if you can get it.
So he's got vesicular lesions over his butt, back, and elbows, and he's fatigued.
Very fatigued. I can give you a hint whenever you need one.
All right, what's your hint?
He also has been having a lot of diarrhea recently. Fatty diarrhea.
Oh, does he have celiac disease? So he needs to stop the gluten.
Nice. Yep, he does have celiac. Do you remember what the rash is called with celiac?
Dermatitis herpetiformis.
Yep, because it kind of looks like herpes, but it's not, of course. And so, yeah, exactly. You have to abstain from gluten. These patients can come fatigued because they have iron deficiency. Other electrolytes or other vitamins, can also be out of whack as well. And then they can also have diarrhea, of course, because of malabsorption. So that's fantastic. You can give dapsone for symptomatic treatment at times, but really the best treatment is abstaining from gluten. There's actually this one time we have this grand rounds in Philly where every medical university will put on a grand rounds, and all the other ones will go to. So like Temple will have one, Jefferson, Penn, and there was a patient that had this really nice dermatitis herpetiformis, and of course he's not eating gluten, but the day of a couple of days before the Philly grand rounds or whatever this was, he was like, oh, I want to come to it. I want to show you guys what it looks like. So he went and ate a bunch of gluten so that he would break out into the rash and then like come to the Philly grand rounds to show everybody what it looked like. I was like,
what a nice patient.
Crazy, man.
Yeah.
But that was dedication.
Huh. I have a follow-up
Anyways, I wouldn't
question.
recommend it.
Yeah,
Tell me.
avoid the gluten. So what are the antibodies that you might check on a
Oh
person
no,
who
Bobby.
has celiac disease?
So we've talked about this before,
We have.
and I didn't know it last time.
Right. This is your Achilles heel to my to my Achilles heel.
Anti-gliadin,
There's three. Mm-hmm.
anti-gliadin, anti-tissue transglutaminase,
Mm-hmm.
and anti-endomysial.
Yes. Very good. You're very good at Googling. So as a follow-up to that, if those antibodies, if you checked a gliadin and it was normal, but you think this person still has celiac disease, what other concomitant disease might they have that commonly is co-associated with celiac disease?
What specific antibody did you mention?
Gliadin?
Is it thyroid disease?
Mm-mm.
Is it diabetes?
It is selective IgA deficiency. And so that's a little gotcha question that shows up a
Oh,
lot
is that all
is
you're saying? Is that you checked the IgG and it wasn't positive?
you check, well, so gliadin and tissue transglutaminase, I believe, are both IgA, and then anti-endomysial is IgG. So that one would be positive, but the other two wouldn't be if the person had selective IgA deficiency.
Oh, I get what you're saying. All right, well done. That's really high yield, actually. People should remember that. IgA. IgA is just super important in general, but specifically in this case.
Yeah, I don't think knowing this, like the specific subtypes of the three different antibodies, is particularly important. But knowing that selective IgA deficiency is like really common in celiacs is definitely worth knowing.
Definitely. All right, Bobby. You have a buddy, and he comes to you and he goes, "Hey, look at my finger. When it gets cold outside, it turns really white, and it's not super painful. It just takes a while, and it comes back, and it's flushed and red and beautiful as ever. But this has happened recently, and I'm kind of concerned about it. If you were concerned about a rheumatologic disease, what would be your number one rheumatologic concern for this person?"
Jeremy? I would be concerned about Sjogren's syndrome.
So, why would you be concerned about Sjogren's syndrome over, for example, like a scleroderma or Crest syndrome?
That's a good question. And I forget that those are different diseases. I think of them all as kind of like one thing, but that's a good point. Yeah,
What's Crest?
Crest syndrome is an acronym. It's like the limited systemic sclerosis versus like Crest syndrome, which is like the limited one that tends to have more like surface skin findings and peripheral findings. So C stands for calcinosis cruris, which is like just calcium deposits. R is for Raynaud's. E is for esophageal dysmotility. S is for sclerodactyly, and then T is for telangiectasias or whatever they are.
Oh,
Telangiectasia?
nice. Yes. Very well done. So yeah, exactly. This person has Raynaud's phenomenon. And so it can be isolated. It can be Raynaud's disease, which is an isolated phenomenon and it's self-limited. It's not going to do anything. But it can also be a hint that the person has underlying rheumatologic disease, among other things. But the classic one is scleroderma. You can also think about lupus and polymyositis and Sjogren's, like you said. So it can be anything. But for the step exam, I think you should really think about Crest syndrome, scleroderma in this case, and know that if it's isolated, it can often resolve by itself, whatever triggered it, whether it be anything from an illness to medication to even emotional stress. As long as when that goes away, there's a good chance that the Raynaud's phenomenon or disease could also dissipate. But you always want to make sure that you check for underlying conditions. And if you want to treat the Raynaud's, calcium channel blockers and phosphodiesterase inhibitors are so far the two best treatments.
Nice.
All right. And we have another. We have a video on YouTube actually that dives into Raynaud's a little bit deeper if you're interested at all. So, Bobby, I have a baby. So now this is pediatric dermatology. This is like
Damn.
up your alley, the bane of your existence. I have a kiddo. They were just born a couple weeks ago, and they come in with this huge hemangioma on their cheek. And so the mom comes to you distressed, and the hemangioma is not next to any kind of vital organs. It's not going to stop the baby from eating or smelling or seeing or anything like that. It's just kind of a cosmetic thing. And the mom goes, "What can you do to help my baby?" What do you say?
You should reassure her that most of them resolve spontaneously, but if the strawberry hemangioma is not resolving spontaneously, I believe you can actually inject beta blockers.
Yes, you don't inject beta blockers, but you can give them topical beta blockers like the timolol that people actually have for like ophthalmic solutions. You actually can rub that on. So that's the first thing, and it's only if they want it, like if they're pushing you for it. But you're right, the answer probably is going to be that it subsides on its own. Now, there are some babies that ultimately do get oral beta blockers, and that's this whole ordeal, giving beta blockers to a brand new baby, right? So the babies have to come in, they have to be monitored closely. When you give them the beta blocker, you have to let them eat with the mom there, because of course they can drop their sugars. You have to monitor their heart rate. And those babies, the reason you're giving them beta blockers is because that hemangioma is somewhere vital. It could be in the neck, for example. They could have something called fasciitis syndrome, where you're worried about the hemangioma continuing to grow, because when it starts off, when you get a hemangioma, a strawberry hemangioma, when you're a newborn, it's small. It gets bigger through by like 6 to 8 months. It's at its biggest phase, and then it starts to involute. So if you're worried that it's going to start getting bigger and bigger and potentially obstruct the airway, go into the eye socket, other things that are kind of detrimental to the baby, then you start oral beta blockers. But if it's in a cosmetic area, if it's on the buttocks or on the back, typically the answer is just do nothing. You can give topical beta blockers if the parents insist. And then for life-threatening or, anything threatening, functionally threatening hemangiomas, you can give oral beta blockers like propranolol.
Cool. For some reason, I vaguely remember a question. This might have been a pimp question that I got when I was on peds, or it might have been a U-World question, and I'm just kind of mixing them together. But if the hemangioma is occurring along the jawline, or there's multiple ones along the jawline, that's actually like a life-threatening area, because it usually means that they have ones that are like also internally, like whatever on the inside. So
it's called Fasciitis syndrome.
Oh, okay, that's Fasciitis syndrome.
Yeah,
all right,
cool. Exactly. So Fasciitis syndrome, just for those that are interested, it's PHACE. So it's not like faces, but faces. I just said the same thing twice. But once you see these hemangiomas covering a large area, it's an acronym, so you can think about other things. And I'll let other people. It's not super high yield, so we won't go into it. But it's just something to know. There is a whole syndrome, a whole acronym for when you get these really gnarly hemangiomas.
Cool.
All right, Bobby. So next patient.
Hold on.
You have.
I have a follow-up question for you.
Oh, I'm sorry. Apologies.
So you see this picture, it kind of looks like Raynaud's, but it's in a baby that's maybe a couple months old that comes in with mom, and it's on one of their toes. What are you worried about?
Oh, this is what you and Heather talked about in that one podcast. It's a web.
Of what?
It's like a web of. What do you mean of what? It's a web of tissue.
No, it's not a newborn baby. They're a couple months old. They were fine at birth, and now they have this.
Oh, well, the
baby's crying. They're kind of inconsolable.
Yeah. Oh, wait. It's a... Oh, no. You and Heather both knew this. I didn't know this. It was in our pediatric podcast. It was a piece of string or something wrapped around the baby.
Yeah, exactly. It's a hair tourniquet. It's actually surprisingly common in children to get a lock of either mom's hair or dad's hair, if they have long hair, wrapped around a finger or toe. And it can get constricted and it can cut off circulation, and it can look similar to this, although you'll usually be able to also see like where the hair is wrapped around their digit. But
Right.
it's actually severe enough that they can lose the digit if it's not caught in time. So just keep that in
Jeez,
mind.
can you imagine
Yeah.
cutting off your
feel
baby's
so
digit with your
guilty.
hair?
Yeah.
Yeah. Jeez. All right. So if you go to the next slide, you'll actually see the hemangioma we talked about.
Nice.
Fantastic. All right, my next vignette for you is a 42-year-old gentleman comes in. He has a history of drug abuse. He has this horrible rash in the lower extremity that looks like cellulitis. You tap it, and he starts screaming. There's so much pain. What are you concerned about? Let me know if you want to hit.
I would be concerned about necrotizing fasciitis.
Well done. Yep, my hint was going to be crepitus. So, exactly. You see someone come in, maybe you think cellulitis, but they're
Is there a picture
purple
associated
skin.
with this? Oh, there it is.
Yeah,
Nice
purple
fade.
skin. There's pain out of proportion, crepitus, bulle, maybe even. Think about neck fash. They need surgery. That is part of the treatment. It's not antibiotics, or it's not just surgery. It's antibiotics and surgery, and quick.
Definitely. What if you saw a similar type picture after somebody had been jet skiing and maybe they had a little scratch on their leg? What's the causative organism?
Probably a mycobacterium.
What if they really like oysters?
Vibrio vulnificans.
Yeah, nice.
That's it.
It just looks similar. Yeah.
Oh. Oh, those oysters when I'm jet skiing just popping out, biting me.
Gotta watch out.
All right, Bobby, you can actually go to the next slide because the vignette is there for you. It's a long one. So, for the listener
you want me
at
to read this?
a 23-year-old woman, newly on oral contraceptives, comes to the dermatologist's office complaining of a rash on her hands, forearms, and face. On exam, her arms and dorsal hands are covered with oozing erosions and ulcers. Alongside these ulcers are patches of hyperpigmented skin. We find that her mother had similar episodes. What is the underlying etiology? And I'll just preface this saying that this is probably the hardest question I have today.
Porphyria, cutanea, tarda.
How did you know that? Damn it.
Cuz, bro, I know things.
How'd you know that? What made you know that? How'd you get
It was
that?
the hands, forearm, and face, and then her mom having it too. I know OCPs are a risk factor for causing episodes because they are metabolized by the liver.
Well done. Yeah, Porphyria, cutanea, tarda. Issue with uroporphinogen decarboxylase. If you go to the next slide, Bobby, you can show the viewers an example of it. But basically, it causes this horrible condition. I've seen it only once, and it often has to do with hepatotoxins. So what I saw, it was actually in the setting of alcohol abuse. So alcohol is a huge one, and estrogen, in this case, OCP. So those are the two biggest insults. You can always see it with viral hepatitis and HIV, among other things. But unlike other kind of porphyria issues, you won't really have abdominal pain. You'll just have someone that comes in with this horrible rash. You'll see that they maybe even have like the port wine urine that we've come to know with this disease. And the treatment really is to like stop these insults, to use sunscreen, because really it's the combination of the hepatotoxin, the light triggering the skin, and then of course avoid exposures like I said. There's been cases of hydroxychloroquine using, but for political reasons we won't recommend it at this time.
Nice.
Yeah, and if you go to the next slide, you can kind of just see for the viewer just the pathway, and you're blocking 5, the number 5 there, porphyria, cutanea, tarda, which is the uroporphinogen decarboxylase pathway.
Right. This is actually allegedly the origin story for, I believe, vampires, because if I remember correctly, consuming heme actually makes symptoms better. I could be getting it mixed up with the other porphyria, but an interesting little historical aspect nonetheless.
Yep, definitely. I think people have called you a vampire, no, before? Or was that
Perhaps.
someone else?
Perhaps.
Perhaps. I'm done fighting. Perhaps.
I can neither confirm nor deny.
All right, Bobby. I got a 21-year-old male comes in, itchy all over, especially at night, and you see the image on the next slide. What do you think it is? One more. Yep.
That looks like scabies.
Perfect. Yep, exactly. So in these people, you see itchy people. You see mainly lesions around the digits, uh, within the folds of the fingers, within the folds of the toes, on the hands. You want to think about scabies. And then what would be like the first line treatment for these patients?
I believe it's topical permethrin.
Yep, it is. Exactly. So another hint for this is if other people have it in the vignette, that's also a good hint. So if this was a 20-year-old college guy and his roommate also had it, think about scabies.
Definitely. It's also fairly common in the homeless population. So if they give you somebody who like comes in off the street, that's also a little tip off.
Right. Or ravers, right?
Right. Raver scabies, which is
Right.
of course
We've had some
glitter.
roommates. Yeah.
Cool.
Fantastic. So my next patient is a 42-year-old gentleman. He comes in with these new papules throughout his body. They're really big and scary, and you think, hey, I've seen these in kids before, but not in adults, and they're kind of umbilicated in the middle. What underlying disease do you think this guy has?
HIV.
Well done. And what does he have? What is his skin finding?
He's got Molluscum contagiosum.
Nice. Yeah, we go to the next slide. You can see a classic case of molluscum. In kiddos, it's self-resolving. You don't need to do anything. If the parents want to do something, they can try to freeze them, or there's multiple treatments. But the answer is going to be do nothing. And then in adults, typically you shouldn't have these anymore because your immune system should have learned what it is and should have fought it off. But if you do, and if it's pretty exaggerated, think about HIV because your immune system is obviously shot at that point. Fantastic.
Got the pox.
You know a lot, Bobby. I'm surprised that you're not going into derm. I feel like it'd suit you. Anyways, I digress. So I have another patient, Bobby. It's a 4-year-old kid comes in, has honey-crusted lesions around her mouth and nose. What is the most likely underlying bacterial pathogen?
That is Impetigo that you are describing, and that is due to, isn't it staph?
It's not staph. Not the
Oh no,
most
it's
common,
strep.
at least.
Yeah, strep.
Strep. Yep. Every time I see the word impetigo, I say it as if I'm saying despacito. For some reason, I always just go impetigo. But I digress. So let's say this patient has a brother also with some new lesions, but these ones are kind of more bullous. But you think it's still probably an infection. What would be the most underlying etiology there? What would be the most common underlying etiology there?
For bullous impetigo, that's staph.
Yep, exactly. Anything bullous, you always want to think staph because staph just creates these bulli. It has the factors. It has some special proteins that allow it to kind of stay like more form. So exactly, normal impetigo, and you can go to the next slide where we see impetigo on the top and bullous impetigo and the remnants of blisters on the bottom. So normal impetigo, think strep. Bullous impetigo, think staph. All right, Bobby. The next slide is just, do you know it or not?
Folliculitis.
Exactly, folliculitis. So if you see something that kind of looks like acne, you see a little bit of pustules, but they're like on a weird distribution, or they're all around some hair follicles, or maybe someone just shaved, think about folliculitis. That's all I wanted to say with this slide.
Mm-hmm. Do
So,
you know the term for people who are shaving who get folliculitis? It's got a special name.
no, I'm thinking about like either pseudofolliculitis or folliculitis barbae.
Right, yeah, I believe it's like pseudofolliculitis barbae, as if it's like shaving related, especially in like the beard distribution.
Right.
Cool.
All right, Bobby. So I have another patient. It's a 23-year-old female. She comes to you with acne, actually, and she says, hey, my acne is so bad. I would like to have some medication for it. And you say, okay, here's some doxycycline. Here's an antibiotic that we often use for acne. What's the thing that you need to warn her about doxycycline?
Photosensitivity.
Photosensitivity. Fantastic. And then she goes, oh, this didn't work for me. I think it is probably worse with my menstrual period. What medication would you give then?
Is it clarithromycin?
Clarithromycin.
Can't you use topical
It's not an
clarithromycin?
antibiotic. Menstrual period. There's two answers in theory.
Wait, what?
So this, she takes Doxy. It's not working for her. She realizes, hey, my acne's worse when I'm menstruating.
Oh, okay, I understand. So you can give her spironolactone.
Fantastic. Or oral contraceptives, but spironolactone is always a good choice as well. And I've seen some physicians do that. And then finally, none of this is working. And you finally go, hey, let's start you on some Accutane. What is Accutane? And what are some of the things we need to worry about?
Accutane is isoretinoic acid, which is a derivative of vitamin A. The main thing that you have to worry about, and that I believe is actually mandated federally, is the patient needs to be counseled about the teratogenic risk. So they have to sign a contract saying that they'll be on 2 different forms of birth control. You have to do a pregnancy test before you start them on the medication. And then the other, I don't know that this is a big risk, but it's something that can show up, is actually they can get pseudotumor cerebri from it.
Yeah, great. Fantastic. So yeah, Accutane teratogenic, huge thing. Pseudotumor, huge thing. There's some concern about suicide. It's debatable. And then also, like, people need to follow up actually basic labs just to look at their hepatic function, because there is some hepatic damage that could occur in theory.
Right.
So
and dry lips
like that. Right. I'll drink. You got that all right.
Cool.
All right. Fantastic.
Are you familiar with the popping subreddit?
Oh no, don't tell me about that. I'm going to be on it later. I follow Dr. Pimple Popper.
Yeah, it's basically like that.
It's good stuff. I like that. That doesn't gross me out. The stuff that grosses me out is like nose and like oral secretions. Like I had a patient a couple days ago who was like bleeding profusely out her nose, and it was also coming out of her mouth. This is in the ICU. And I was just sitting there like, oh, and the ICU attending was looking at me. He's like, "Don't you want to be a dermatologist?" I was like, "What is that? What does that mean? This is not dermatology."
Blood usually stays on the inside.
I was like, dude, my one thing is like the mouth and like the nose and things coming out of it. I was like, get one of the anesthesiologists in here; they can fix it.
Mm-hmm.
He was really funny. He's like, all right, we can't wait for ENT. Let's get some of these Rhino rockets and put them up there. He's like, I can do them. Or, Bo, do you want to put one in? And I was like, no, you can do it. I love that in like intern year. Like you're not asking for like Rex or anything. You don't really care. So like I'm sure if I was a med student, I'd be like, oh yeah, Dr. Wong, of course. Like let me help you put a Rhino rocket in. I was like, no man, do it
I'm
yourself.
good, bro. You got this.
He's like, I heard it's just like a tampon up the nose. I was like, that doesn't mean anything to me, man. I don't know. I don't know how to use a tampon.
Like, I've never used that before either, so I'll just leave this up to you. If anything, I'm less confident now that you said that.
Right. I was like, I'm going to sit here and actually write my note.
Yeah.
So, anyways, I digress. So, I have another patient come in, Bobby. They're 25 years old. They're coming to you as a dermatologist from their PCP, and they're concerned because they have these kind of like darker brown discoloration around their armpits. So what do you want to educate them about in this regard? And you can look at the next slide as a hint.
They need to get their sugars checked.
Why?
Because they have diabetes.
They might not.
I
forget. They're at risk for diabetes.
Yeah, they have. Gosh, what is it called? It's like vellus skin with hyperpigmentation.
It's almost like a little thicker, like acanthotic.
Right. Acanthosis nigricans.
Yep. Nigricans. Yep. Exactly. So the patients like this, you want to think about like metabolic syndrome, and you want to make sure that they're doing okay in that regards. There's a female population that you want to be concerned about, where I think a good step hint in general would be a female that comes in. She's having trouble menstruating and also has this, and you would think about a certain condition.
PCOS.
Yep, exactly. PCOS, polycystic ovarian syndrome. In which case, you would treat them kind of almost like a diabetic, as well as giving them things like OCP. So, fantastic. I will drink for that since I think you got part of it right.
I'll drink too. Yeah, I think I believe metformin's actually becoming more popular in the treatment of PCOS
Mm-hmm.
because I suppose it helps with symptoms as well.
Fantastic. So our next patient is a 17-year-old male. He comes in. He has these just kind of uncircumscribed, kind of random red erythematous macules, largely, maybe some papules around his entire body, and there's one larger patch on his belly, right by his belly button. Otherwise, they're all kind of small and maybe like 1-2 millimeters in size. What is the diagnosis?
Pityriasis rosea.
Well done. Yeah, Pityriasis rosea. You can go to the next slide. It's a giant, kind of red, angry rash, but it's often asymptomatic. Maybe it's sometimes itchy, but you have this Harold's patch, which is kind of classic. We don't really know why it happens. I think most people think it's probably like some type of virus. Like, you think about like HSV6 and the rashes that those cause. And I think Pityriasis rosea is probably a viral exanthem, but in any case, just know what it looks like so that if you see it, you can diagnose it appropriately. I think it can be confused with sometimes secondary syphilis, in which case you would want to get things like an RPR.
Cool.
Nice. And then the next slide, Bobby, we're just wrapping down now. Actually, you did much better than I thought. These are just images of squamous and basal cell carcinomas. So for the listener at home, remember basal cells are pearly, heaped up borders, while squamous, you're probably going to see more ulcerative. If it is squamous, you can also think about like chronic wounds. So chronic wounds, you can actually have squamous cell cancer kind of grow within or around chronic wounds, and that makes sense because the cells are constantly dividing to kind of like help this wound, and if they're dividing, there's a higher chance of them becoming cancer, and therefore you get these squamous cell cancers.
Right.
Remember, basal cell is the most common type of skin cancer, both of which are treated with excision, whether it's normal excision or if it's on the face or sensitive body parts, most surgery. Anything
Right.
you want to add?
Which one tingles?
Tingles?
Mm-hmm.
There's one that tingles. Oh
Yeah.
gosh. I don't know, man. I think I'd be guessing. I think squamous goes deeper, so I would guess squamous.
Squamous likes to involve the neural sheath for whatever reason,
Yeah.
so it can cause more neurosymptoms. And the actual name for a squamous cell carcinoma at the edge of a chronic wound is actually a Marjolins ulcer, which does show up from time to time.
Definitely. That's a great point. And then finally, the last slide here we have is just a bunch of different melanomas. It's just good to know if they're going to give you melanoma, it's going to be a question along the lines of what do you need to educate the patient on? And it's going to be the A, B, C, D, E. So just know those of melanoma. Just know that asymmetry and borders and colors and diameters and everything else, which is just a cop-out. But melanomas are scary. They're treated better ever now compared to 10, 20 years ago with immunotherapy. But still something to just know if you see it on the test, what to look for and what to educate the patient on. Otherwise, I don't really think it's particularly high yield to know much about melanomas. I think there's one mutation that people should know for melanomas.
Right, it's the nodular type, isn't it? Because that's the type that tends to grow down instead of laterally. Because the main predictive factor in terms of melanoma outcome is actually Breslow's depth of invasion.
It is Breslow's death, yep. Yeah, and I was thinking of like an actual genetic mutation. I think it's like the BRAF mutation.
Oh.
Which is in one of the sketchies.
Yeah, I think you're right. I think it is BRAF or...
Yeah.
That sounds
right.
But
other than that, I don't think there's too much to know about melanomas, for at least for the STEM exam.
Lentigo maligna?
Lentigo maligna, that's very right. That's a nice little slow sliver of a melanoma. Fantastic. All right, Bobby, if you go to the next slide. That is it for today. Bobby, how was your drink?
It's pretty good. It's a pretty solid IPA. It was the Little Huma, or Huma, H-U-M-A, from Shorts Brew that they so graciously sent to us. I would give it a 7.5 out of 10. It's a pretty solid IPA.
All right. And then if I go to Beer Advocate, the average is 3.7, which is 7.4 out of 10. So that's fantastic. Was it a pretty strong IPA or?
No, it's not too strong. It's not. It's only like 4.5% alcohol too. So in terms of like actual alcohol content too, I think it's a little light for an IPA, but it's pretty solid. I'd drink it again.
Nice. I had the Rolo from Longship Brewing Company. I actually really enjoyed this brew. I've never had salted caramel stouts or salted caramel anything in regards to brews. But this is really good. You know what it reminds me of is a Guinness. It tastes a lot like a Guinness. So I really like it. I would give it an 8 out of 10.
Nice.
And let me see what if there's any. Here, Untapped has a review. On average, I see a 3.81. So that would be what, 7.6?
Mm-hmm.
So that's fantastic. Yeah, Rolo. So overall, a couple great brews today.
Nice.
Awesome. All right, guys. Well, on the screen, you can see our website. If you're interested in anything else that we provide, we have podcasts, we got videos, we got multiple practice exams up. You can see our buzzword store from there. And also our handle for Instagram. If you're interested in following us and our antics, you can follow us there. But until next time, we will see you guys soon and look out for some more episodes. Cheers.
Later.